Hi, everyone, and thanks for coming and watching this talk. I look forward to presenting some information over the next few minutes on endocrine conditions in patients who have or who have had cancer. So let me start by sharing my slides and let's see. Here we go. So my name is O.P. Hamnvik. I am an endocrinologist at Dana-Farber Cancer Institute and Brigham Women's Hospital, as well as an assistant professor of medicine at Harvard Medical School. So I'm going to be talking about some common endocrinology issues among cancer survivors. And the first question you might have is, what is endocrinology? So I'm going to start there. And endocrinology is the science, the branch of medicine that focuses on hormones. Hormones are molecules that are made by various glands in the body and secreted into the blood. And from the blood, the hormones can really travel to all over the body and have effects on the entire body. So I listed on this slide some of the more common endocrine organs, some of the common glands. And you may recognize many of these names, like the thyroid and the adrenal, the testes and the ovary. Some of them might be a little bit less familiar, like the pituitary gland or the parathyroid gland, but they are all sort of under the umbrella of endocrinology. It turns out that in patients who have cancer or who have had cancer, it's fairly common to get issues affecting one or more endocrine glands. And so that's what I will be talking about today. Because there are so many endocrine glands, I won't really have time to talk about all of them, but I'll be talking about sort of the top three. So I'm going to be talking about issues of blood sugar, and that is under the control of the pancreas. I'll be talking about issues that affect the thyroid, and then also about kind of bone health topics as they relate to cancer and the cancer patients. Obviously, there are other endocrine issues affecting the pituitary gland and the parathyroid and the adrenal, as well as the ovary and testes, but we won't really have time to go into those today. So I'm going to start by talking a little bit about issues of high blood sugar in the cancer patient. So I'll preface this by saying I could have given this entire talk on blood sugar in the cancer patient because this is a complicated topic. So because I do want to talk about more than just blood sugar, I'm going to sort of give you a bit of an overview, and hopefully you'll be able to go into more detail in the situation that you might be in with your oncologist or your primary care clinician, or indeed your endocrinologist if you have one. So the blood sugar, the sugar in the blood, is something that is very tightly regulated. There are some ups and downs, and typically with eating, so breakfast, lunch, dinner, or snacks, the blood sugar will go a little bit up. As the body is processing the sugar, the blood sugar goes back down again. And with exercise, you might have the blood sugar go down a little bit faster. And the reason that the body keeps the blood sugar in such a narrow range is that there are dangers to having blood sugar that's too low, and there are dangers to having blood sugar that's too high. Sugar that's too low is a problem because the brain really relies on sugar as its fuel. So if you don't have any sugar in the blood, then the brain isn't getting any fuel, and you can end up in coma, or in fact even die. The flip side is having high blood sugars can cause especially long-term issues. And that's what we call diabetes. And so you might be familiar with some of the long-term complications of diabetes, things like blindness, kidney failure, dialysis, heart disease, and ulcers and amputations of the feet. So it's really important for the body to keep the blood sugars in a really narrow range. And it does so through a really intricate system of regulators. But the key regulator is the pancreas. So the pancreas can basically sense the blood sugar, and based on what it is sensing, it can decide whether it wants to make the hormone insulin, which it will do if the blood sugar is high, or whether it wants to not make insulin. So when the blood sugar goes high, the pancreas makes insulin, and insulin helps the sugar go from the blood into muscle or into the liver, where the sugar can be stored and be ready for use later. When the insulin levels drop, the liver in particular will start to release its sugar back into the blood so that it can maintain steady blood sugar levels. Because it's such a finely tuned system, it is prone to things going wrong. So diabetes is common in patients with or without cancer. And in part that is mediated, that is due to the high rates that we have in our country of overweight and obesity. But in the cancer patients specifically, there are certain things that can really contribute. So one would be if the cancer is one that affects the pancreas. So if it is pancreatic cancer, then it is not surprising that it will make it more difficult for the pancreas to function, and that can lead to the blood sugar going high. Many of the cancer treatments can also send the blood sugar high. So that would be things like steroids would be the typical one. So dexamethasone or Decadron, prednisone. And with high blood sugar or with those medications, the blood sugar goes high during treatment, but tends to go back to normal again when you stop the treatment. There are other medications also that can raise the sugar while you take them. A few examples would be alpelisib. The other name for that is Piqray. It's everolimus and temsirolimus. Those might be familiar to some of you. I want to take 1 minute and specifically point out that immunotherapy, or what we call immune checkpoint inhibitors, can also send the blood sugar high. Pretty rare, but when it happens, it is a permanent diabetes usually. And so patients who receive immunotherapy who develop high blood sugar should be particularly aware of the implications of that on their kind of long-term need for blood sugar lowering medications. So, why do we care that the blood sugar might go high during the cancer treatment? Well, in part, we don't care, and maybe we don't care enough, but in part, we do tend to allow the blood sugar to go higher during cancer treatment. And the reasons for that is that most of the complications of cancer, of high blood sugar, are long-term. And so in the sort of few weeks or months that chemotherapy is sending the blood sugar up, it's reasonable to allow the sugars to go a little bit higher. The flip side is, though, that there are some short-term complications of high blood sugar. One big one is an increased risk of infections, which might be particularly relevant to patients who are prone to infections due to their cancer chemotherapy, for example. There is also a growing realization that having high blood sugars might actually, use the word, feed the cancer. That the cancer also needs nutrients, and if the blood sugar is high, that is a ready source of nutrients for the cancer. So while we are still studying this relationship between high blood sugar and cancer outcomes and trying to get to grips to what the significance of that is, we do tend to not totally let the blood sugars go uncontrolled even in patients who are in the midst of chemotherapy. So typically a normal blood sugar is between 70 and 180. We might allow the blood sugar to go up to about 200 without doing anything in the setting of active cancer treatment. But if we see the blood sugar go into the 200s or 300s, that should be addressed, at least if it's not coming right back down into the normal range. There are many different ways of addressing high blood sugar, and I won't go into the various medications and so on, but just to say that if you are seeing in your results that your blood sugar is routinely greater than 200, you should talk to your team about how you might manage that. It turns out, though, that some of the treatments for the cancer can predispose you to develop diabetes or high blood sugar even later in life, even as the cancer is fully gone and you're sort of going about your life, the changes that the chemotherapy or radiation therapy caused in muscle or liver or pancreas or other parts of the body might make you more predisposed to develop diabetes later in life. Now, it turns out that there are guidelines for everyone to be screened for diabetes once you sort of hit middle age. And so that is also definitely true for the cancer survivor. And typically we do that either with a fasting blood sugar, or there's a test called the hemoglobin A1C that can assess what is going on with your blood sugar sort of on a more long-term basis. So those are reasonable tests to get as a cancer survivors, maybe every year at most. We don't need to get it more often than that. If you don't have any other risk factors, it's reasonable to space it out to getting the test every few years. So that is a very broad overview of blood sugar in the cancer patient. I'm going to move on because I want to cover a few other topics, and I'm going to move on to thyroid disease. So the thyroid gland is here at the nape of the neck, and it serves many purposes. It controls a lot of things in the body through the secretion of the thyroid hormone. To sort of simplify what it does, it can control how fast everything works in the body. So how fast is your metabolism? How efficiently do you use energy? What is your body temperature? Do you tend to run hot or run cold? And then it has effects on many organs, the heart, the intestines, the brain, the muscles. So if you have a problem with the thyroid, you can get symptoms from any of these areas. In the cancer patient, there can be issues with abnormal thyroid structure, meaning that the thyroid looks abnormal. And that is typically what we call thyroid nodules, as you can see on the picture here, little lumps on the thyroid. So those, of course, can happen in people who have a history of cancer or not, but specifically in those that are survivors of cancer, there is a higher risk of nodules. In part, it's because you might have more scans than your typical person. And so we pick up these nodules that otherwise would have gone unrecognized. But there is a real increase in the risk of actually developing these nodules if there was neck radiation occurring in childhood. Whether neck radiation in adulthood is a risk factor is a little bit less clear. And I think right now the conclusion seems to be that adults who get neck radiation are probably not at increased risk of thyroid nodules. With that being said, if there has been radiation to the neck, at least in childhood, the recommendation is to examine the neck once a year. So that can be done by the primary care physician and basically involves pushing firmly at the base of the neck and trying to feel any lumps or bumps. A sort of more sensitive way is to get ultrasounds, and ultrasounds will pick up every nodule. But the problem is it picks up a bunch of nodules that would never have caused any problems. And therefore, we don't recommend routine ultrasound. We recommend getting an ultrasound only if there might be a nodule that can be felt by the clinician who examines your neck, or if you have symptoms from the neck, if you are feeling lumps or bumps, if you have hoarseness of your voice, if you have trouble swallowing, those types of things. So, all right, well, let's say a nodule is found. What do we do next? Well, we do a few things. So one is that we measure the thyroid blood tests to see if this nodule is making thyroid hormone, which can cause you to have too much of the thyroid hormone. That's actually pretty rare, but it's on the list of things we have to do. We then will get an ultrasound, and on the ultrasound we look at various features of this nodule. How big is it? Does it have features that look concerning? And what we're specifically concerned about is thyroid cancer. So about 10% of these nodules will be a thyroid cancer. The other 90% are benign nodules that are not cancerous. But we kind of have to somehow figure out, is this nodule in that 10% that's cancerous that has to be removed with surgery, or is this one that seems to be pretty benign? So one way to figure that out is to look at the ultrasound and see what the nodule looks like and see whether it looks more on the with many malignant looking features, or if it looks very benign. And if it looks benign, and we may not need to do anything else other than repeating an ultrasound in a year or two. But if it does not look fully benign, we would biopsy, and the biopsy is done with a very small needle right through the skin of the neck into the thyroid with a little bit of local anesthesia. It's a very low risk procedure, and it will most of the time give us an answer about whether this is benign or cancer. If it is cancer, the treatment is to remove it surgically, so that's a thyroidectomy. Sometimes we give radioactive iodine, which is radioactive, but it goes specifically to the thyroid area and will destroy any leftover thyroid cancer cells that might be left behind after surgery. So the good news is that of all the cancers in the world, thyroid cancer is one that really has a very, very good prognosis. So even if you were unlucky and you got this as a second cancer, chances are that you will do very well, and this will not be anything more than a nuisance as you have to go through the surgery and potentially have some other treatments. Because that's not true for everyone, we don't leave the cancer behind. We do take it out and treat it so that we're not, we don't want to leave people with an untreated cancer that could become a problem. The other set of issues that can affect the thyroid is abnormal thyroid function. So we talked about nodules being an abnormality in what the thyroid looks like in the structure, but it might be that this thyroid might look normal, but it's not working right. And that's what we call abnormal thyroid function. So the thyroid gland is secreting thyroid hormone, which, as I mentioned, goes into the blood and goes to all parts of the body to exert the effects that the thyroid hormone has. But the thyroid isn't just making thyroid hormone out of the blue. It is making thyroid hormone under the control of a different hormone, which is called TSH. So TSH is actually a hormone made from the pituitary gland, which is right at the bottom of the brain. And the pituitary gland is kind of the master gland. It controls a bunch of different endocrine organs, including the thyroid. The pituitary can sense how much thyroid hormone is floating around in the blood, and will determine, based on what it's sensing, how much TSH to make. So it actually means that when we are trying to figure out if you have abnormal thyroid function, what we measure is the TSH. Because even if the thyroid hormone, which we call T4 or T3, even if the thyroid hormone is dropping by just a little bit, not enough that we pick it up on our blood test assays, the brain will pick it up, the pituitary will pick it up. And so very quickly, the TSH will rise in an attempt to stimulate the thyroid to make more of the thyroid hormone. So the TSH is a very sensitive test and a good test for thyroid dysfunction. So that's sort of what we might see in the blood work is, well, if you have a normal thyroid function, we get normal TSH and a normal thyroxine or thyroid hormone or T4 level. If you have too much thyroid hormone being made by the thyroid gland, the pituitary will sense that and will stop making TSH. And then vice versa, if you're not making enough thyroid hormone, the thyroid hormone level is low, and the brain senses that, the pituitary senses that, and the level of TSH goes up in an attempt to stimulate the thyroid. So what might be symptoms that you have that you might have if you have abnormal thyroid function? So I listed them here, and on the left you see symptoms of an underactive thyroid, and on the right you see the symptoms of an overactive thyroid. I will point out that these symptoms are common even in people without thyroid disease. Maybe particularly common if you have cancer currently, or if you have sort of leftover symptoms from previous cancer treatment. Things like constipation and weight gain, those might be symptoms that we all have to some degree. And then vice versa, having some weight loss or feeling restless, those are very non-specific. So it is very difficult to know whether you have thyroid disease based on just the symptoms, because there's such an overlap with normal symptoms of living in the 21st century, or symptoms indeed of kind of the cancer or previous cancer treatment. So it's a good thing that we have good tests, blood tests that we can use to figure it out. But if you have these symptoms, we would recommend just sending the test. If it's normal, well, it's not your thyroid, and we can move on and look for other things. But if it's abnormal, then it's pretty easy to treat. So specifically, we talked about cancer survivors, and why do I talk about the thyroid specifically? Well, the reason is that there are a lot of situations where the cancer survivor will be at a high risk of thyroid function abnormalities. So if there has been radiation to the neck area where the thyroid is, that is associated with an underactive thyroid. If you are receiving or did receive immunotherapy as part of your cancer treatment, you get this situation called thyroiditis. And in the thyroiditis, the thyroid gland will initially release a bunch of thyroid hormones. So you have too much, you have an overactive thyroid, and then it kind of becomes scarred and damaged. And so you end up with a lifelong underactive thyroid. So that's what we see with these immune checkpoint inhibitors or immunotherapy. And then there are other medications that we use in cancer treatment that can cause mostly an underactive thyroid. So in patients who receive these medications or who had neck radiation, we do recommend monitoring of the thyroid function, usually a TSH. Sometimes we do a TSH and a measurement of the thyroid hormone, which is the free T4 measurement, regularly. And that could be as often as every month if you're actively undergoing treatment, or that could be every 6 to 12 months if you are no longer actively getting treatment. And I'll just mention too that thyroid disease is really common. So separate from being a cancer survivor, many of you will have thyroid disease just because it is a common disorder in the human population. So in terms of treatment, I will focus on treatment of hypothyroidism, because hyperthyroidism and overactive thyroid is less common, and treatment's a little bit more complicated. So it usually would be under the guidance of an endocrinologist, or at least a knowledgeable generalist. But for hypothyroidism, the treatment is to just give you back the thyroid hormone that the thyroid gland is no longer capable of making. And typically we use levothyroxine, which is the generic medication that contains the hormone. Most patients, something like 80–90% of people, will feel fine, and their numbers will look good when we measure them on levothyroxine. We usually use the TSH as our guide when we try to figure out if the dose is right or not. And in the beginning, there's often a lot of tweaking of the dose to find the dose that's right for you. But typically, most people, we can find a good dose and they stay on that dose for life. But there are some patients who either they say, they just don't feel good on generic levothyroxine, or we're having issues with getting the numbers right. We find that the TSH is high 1 month and then low the second month, and we sort of might want to go down to other options. So typically, the second line option would be one of the brand name formulations of thyroid hormone, Levoxyl, Synthroid. There might be others also. The advantage there is that you're getting the same formulation every single month when you go to your pharmacy. You get the Levoxyl, you get the Synthroid every single month. With generic, you might get a different one from month to month, depending on what the pharmacy happens to have in stock. And that can sometimes be enough to throw things off. There are sort of a third line option, which are these either gel capsules or a kind of a liquid form of thyroid hormone. Tyrosint or Thyroidity are some of the names, brand names here. And those are really pretty rarely used, both because they're very expensive and because most patients do fine on the first or the second line medications. There are a couple of options that I don't use very often, and I don't think should be used often. One of them is the second thyroid hormone. All of the levothyroxine, Levoxyl, Synthroid, Tyrosine, all of those have one form of the thyroid hormone that we call T4 or thyroxine. And that's the main form of thyroid hormone, but the gland actually makes a second form, which we call T3. There is a school of thought that perhaps we have to also give patients T3 so that we're giving back both of the hormones that the thyroid makes. When people do that in sort of a blinded way, when we give it to patients, people don't actually feel better when they get the T3. Most patients feel totally fine on just the T4 alone. But there's a subset of patients that might feel better if they get both of the thyroid hormones replaced. So very rarely I will recommend this medication, T3 medication, which is called either liothyronine or Cytomel. So that's used selectively in patients who have residual symptoms, even after we've tried to optimize their standard thyroid hormone replacement. The one formulation that I do not use and do not recommend ever is the formulation of thyroid hormone that is made from ground up pork thyroids. So the idea is that by giving you an actual thyroid gland that has been ground up and made into a tablet or a capsule, you're giving not just T4, you're not giving just T3, so the two main thyroid hormones, but you're giving everything else too that maybe we don't understand. So maybe that's a better thing. The problem is that these forms of thyroid hormone, they actually have they have a kind of a misbalance between the two forms of the main thyroid hormone, the T4 and the T3. So patients end up with way too much of the T3 form and not enough of the T4 form of thyroid hormone. And that can lead to all sorts of problems, including symptoms of too much thyroid hormone. So I do not recommend using those really ever. I'm going to move on to the last topic that I want to cover today, which is bone fragility. So you might argue, well, bone, is that an endocrine organ? Is that a gland? And bone, we don't think of bone as an endocrine gland, but bone is an organ, part of the body that is very strongly influenced by hormones made by glands. And as a result of that, the sort of management of bone strength has fallen under the umbrella of what we do as endocrinologists. So that is bone strength, meaning what is the risk of breaking a bone. What we do not manage as endocrinologists would be things like arthritis, which is more kind of joint, let's say, wear and tear, for want of a better word. That is not something that we manage, but bone strength falls under our specialty. And it turns out that cancer survivors are at risk of developing bone weakness or bone fragility. And why is that? Well, firstly, it is because patients who have undergone cancer treatment are at risk of having low levels of estrogen or low levels of testosterone. So if we look at estrogen, many types of chemotherapy can cause women to go into menopause early. And in the setting of estrogen responsive cancers, like breast cancer that grows in response to estrogen, the oncologist might recommend specific treatments to lower the estrogen. So those will be medications like Leuprolide or Lupron, or aromatase inhibitors, and that would be letrozole or anastrozole would be typical medications that are used there. So now that you're blocking estrogen, you're blocking the effect of estrogen on bone. And it turns out that bone really, really needs estrogen to maintain its strength. So when the estrogen levels drop, the bone becomes more fragile. This is actually what happens to women as they go through menopause. And this is why bone fragility, which is what we call osteoporosis, is more common in women because men don't go through a menopause, but women do. So women lose their sex hormone when they hit menopause, and therefore they have a rapid weakening of the bone happening right after menopause. And that can be made worse by many of these cancer treatments. Now, men also can be at risk of osteoporosis if they have treatments that lower testosterone. And the classic one here will be some of the treatments we use in prostate cancer to block or lower testosterone levels. But there are other medications used in cancer treatment that can also weaken bone, and steroids would be the big culprit here. Dexamethasone or Decadron, prednisone, those might be familiar names. And that's especially if they are used at high doses or over a long period of time. So taking some Decadron or dexamethasone here and there for nausea after chemo, probably not a big deal. But taking dexamethasone for months and months on end as part of a treatment course for a lymphoma or a leukemia, that could definitely affect the bone strength. And then finally, there's radiation, and radiation to the bone will weaken the bone that's in the radiation field and predispose that bone to fracturing. So in order to know whether your bone is nice and strong, so it looks, lots of white as in the top figure here, or if it is getting weaker with this kind of lack of whiteness that you see on the bottom here, we obtain a test called a bone density. A bone density, or the other name is DEXA. This scan is kind of like an X-ray. It's a low radiation X-ray. And by analyzing the X-ray, the computer can basically spit out a measurement of bone strength. Every woman should get that at age 65. Many people will say that men should get it at age 50. But it should be obtained earlier if you have other risk factors. So if you were a patient who went through menopause at age 35 because of chemotherapy, or if you are a patient receiving anastrozole as part of your breast cancer treatment, you should get a bone density now, basically. In addition to the bone density, which will tell us if you have osteoporosis or osteopenia, or if you have normal bone strength, we can also make the diagnosis of bone fragility or osteoporosis if you've had what we call a fragility fracture. So if you broke a bone with minimal trauma, that's telling us already that there's bone fragility. We don't need a scan to tell us that. We'll still get a scan, but even if the scan doesn't show osteoporosis, we might label you as having osteoporosis if you broke your hip after a minimal trauma. If you had a compression fracture of your back, those will be the most typical types of fractures. So if you have bone weakness, we recommend certain supplements. So we recommend a calcium and vitamin D supplement. So what do you actually take? Well, we typically aim for about 1,200 milligrams a day of calcium, and you can get that through your diet. But it does require 3 servings of dairy every day, milk, cheese, or yogurt. You can also use calcium fortified orange juice or almond milk or soy milk or something like that. But 3 servings a day can be a lot for many people. So many people choose to supplement with a calcium tablet. And for most, I just say get the cheapest one you can find, which is usually calcium carbonate, to add to whatever you have in your diet. And then you should aim for 1,200 between diet and the supplement. So you can use calculators to figure out how much calcium you typically have in your diet. And so I would recommend doing that and then adding calcium supplements to bring you up to 1,200 milligrams. If you are taking omeprazole or esomeprazole, that would be Prilosec or Nexium, you will not absorb calcium very well because you need acid to absorb calcium. The same is true if you're older. If you're over 75, you make less stomach acid, so you're not absorbing calcium quite as well. So if you fall in that category, instead of getting the cheap calcium carbonate, it might be better to aim for calcium citrate. And so you'll find that in the supplement section at the pharmacy. And again, you may have to take more tablets of calcium citrate to hit the number of milligrams that you need, but it will be better absorbed. It turns out that our gut cannot absorb more than 600 milligrams of calcium at a time. So let's say you have absolutely no dairy in your diet. You need to get 1,000 milligrams as a supplement. You're probably better off taking 500 milligrams twice a day, because if you try to take the full 1,000 milligrams in one go, you're just not going to absorb all of it. The second supplement that we recommend is vitamin D, and we might use blood tests of vitamin D levels to help guide how much you should take. For most people, though, taking 1,000 units a day will get you to that target blood level of vitamin D between 30 and 50. You might get 1,000 units a day in your calcium supplement, because most of them are calcium plus vitamin D. Or many of the multivitamins, especially the ones that are meant for people above age 50, many of them will have 1,000 units of vitamin D already. So you might already be getting vitamin D in your calcium or your multivitamin, but if you're not, you can take a separate supplement to get at least 1,000 units. 2,000 is also fine. So that's the one thing you might do yourself. The second thing you might do yourself will be exercise. And for exercise, I tend to put a lot of emphasis on sort of aerobic or impact exercise, things like dancing, running, walking. The idea here is that you are forcing your bones to bear weight. It's weight bearing. And in doing so, the bones can sense that there is a need for the bone to be strong because it's bearing weight. And so the bone density can get better. And it'll also help with balance. The more active you are, the better your muscles are at maintaining balance. And so that's another reason to focus on some of these impact exercises. In terms of kind of doing more kind of lifting of weights, the kind of muscle building types of exercises, I think that's worth doing. They will help with balance. They will give you a little bit of padding so that some muscle to protect your bones. And they might also help you with avoiding falls, again, because you have more muscle, your balance is better, you're less likely to fall. Many patients also like to do kind of balance training, specific balance training, things like yoga or Tai Chi or Pilates, which is also obviously fine. There's just a little bit less data research telling us whether that's something we should recommend to everyone or not. Physical therapy can help. If you have a knowledgeable physical therapist, they can really help you with exercises to do, with posture training, with balance training, and so on. So that is certainly a reasonable thing to do. Also, and how about things to avoid exercise-wise? Well, if your bone density is extremely low, we might start to limit many types of exercise or many types of activity. But for most people, you don't need to limit too much. We might recommend avoiding bending at the spine. So if you're picking something up from the ground, bend your knees, but keep your spine straight. We might also recommend not doing a lot of twisting of the spine, because that can also put basically a lot of energy on the spine, which can trigger a fracture. And very high impact exercise, I did say that some impact is good, but a lot of jumping is probably not beneficial. But those things that I just talked about, calcium, vitamin D, exercise, most of the time at best, they will help you maintain your bone density. They might reduce your risk of fracturing by 15%. But they kind of pale in comparison to the prescription treatments that we have. So if you have osteoporosis, we do recommend pharmacologic treatment, prescription treatment. And so that is certainly the case if you have osteoporosis. If you have osteopenia on your bone density, we might still recommend these sorts of treatments, especially if you have other risk factors, like you are taking an aromatase inhibitor for your breast cancer, letrozole or anastrozole or others, for example. There are other risk factors too. So what treatments do we have? Well, we have only a handful, so I'll go through them now. And the first one is called raloxifene, or the brand name is Evista. It is kind of an anti-estrogen, but it acts just like estrogen on bone. It turns out it's not very effective. It has some side effects that include blood clots, and it can also worsen hot flashes. And because of that, like not very effective, a fair amount of side effects, we don't use it very often. We tend to reach as a first line treatment for alendronate, and the brand name here is Fosamax. It's the only treatment other than raloxifene that is a tablet. It's taken once a week for 5 years at a minimum, 10 years at a maximum, and it can reduce your risk of breaking a bone by maybe 30%. The main side effect is GI upset, heartburn, sometimes nausea, sometimes kind of bloating or burping. In that case, we might instead recommend the intravenous form of alendronate. It's a little bit different, so it has a different name called zoledronic acid, or the brand names here are Reclast or Zometa. And this is given as an IV, so you don't end up with any GI side effects. And it's given either once or twice a year. Usually I have in my mind, as a minimum duration treatment is 3 years, and we can go as long as 6 years. By giving it IV, you end up getting more of the drug into the body than when you take the tablet alendronate, and so it's more effective. So it's reducing your risk of breaking a bone, maybe cutting that risk in half, maybe even more. The main side effect here is that maybe 1 out of 5 will have a flu-like reaction. So the flu-like reaction is a low-grade fever, muscle aches, joint pains. It usually lasts only for a couple of days, and it's usually only with the first infusion. So I always tell people, don't schedule your infusion the day before your daughter's wedding. Do it at a time where you can take a couple of days to recover if you are one of the unlucky ones. With infusion number 2 or 3, it doesn't tend to happen again. So it's sort of primarily the first infusion. The next option is denosumab, and the brand names are Prolia or Exgeva. It's an injection every 6 months, and it's just given as an injection underneath the skin. So you don't need an IV. The visits are quick. This is just as good as the denosumab, as the zoledronic acid, 50 to 70% fracture risk reduction, but and no flu-like reaction. So that all sounds great. The problem with denosumab is that while it works really well while you take it, as soon as you stop it, you actually pretty quickly start to lose all the bone that you gained. And so either you stay on it for life, and that's what the guidelines would say to do, or we are sort of trying our way around giving another medication like the alendronate or the zoledronic acid as a way to kind of lock in place the bone that you gained. But those methods are not yet kind of well established or well studied, so it is a tricky medication in terms of figuring how to stop it, if ever. So then we get to the more stronger medications, and this is teriparatide or abaloparatide, so Forteo or Tymlos. They are daily injections that you take for 2 years. And they have at least a 70% fracture risk reduction. So they work really well. After the 2 years, you have to follow it with something else. And that could be any of these other medications. And, other than being an injection, they tend to be pretty well tolerated. They can cause some aches and pains that usually goes away over time. The big one for cancer survivors to know is that we cannot use these medications if you have a history of radiation therapy. And that is because these medications have been associated in rats with a rare form of bone cancer called osteosarcoma. In humans, we've had teriparatide on the market for 10 years or more at this point. And in humans, we have not seen this association with osteosarcoma. But because radiation can also increase the risk of osteosarcoma, we try not to kind of give you 2 things that would potentially increase your risk. So we don't use it in people with a radiation history. The final medication we have is called romosozumab or Evenity. It's a bit of a newer medication. It's a monthly injection that you come into the office for every month for 1 year. And it's the most effective medication we have, 80 to 90% fracture risk reduction, but you do have to follow it with something else, just like many of these medications. So you can go with any of the other medications. It is a new medication, so we don't necessarily know all of the side effects and so on yet. It also carries a warning that it might increase the risk of heart attack or stroke. So based on that, we don't use it if you have had a heart attack or stroke, I guess, in the past 12 months. And we might be more hesitant if you have a very strong if you have a lot of risk factors for heart attack or stroke. I will say whether this medication actually causes heart attacks or stroke is unclear, because the studies we have are pointing in different directions on that question. Hopefully we'll have an answer once the medication has been on the market for a bit longer, but for the time being, it does carry this warning. So I'll end with, well, you may have heard many objections to some of these medications. So one thing you may have heard is, well, yeah, sure, the bone density is getting better with these treatments, but the bone that's being built, it's not healthy bone. And there I would say, well, how do you define healthy? I would say bone that does not break is healthy. And all of these medications have been shown really conclusively to reduce your risk of breaking a bone. We just talked about that risk reduction being 30, 50, 70, maybe even 90% with some medications. So that one is really just not correct. Well, you may have heard about this thing called atypical femur fractures. And this is a side effect of pretty much all of these medications, where you can develop a very unusual type of fracture of the middle of the femur, the thigh bone. And it is a side effect of these medications. So you might say, well, I'm taking this to prevent fractures. Why would you give me something that's causing fractures? And the reason is that this side effect is extremely rare. So the quoted number is about 1 in 10,000. It's probably even lower than that. So 1 in 1,000 and probably even lower than that. But that compares to the 1,000 fractures that we might prevent for each one fracture that we are causing. So the risk-benefit ratio is still very much in favor of using the medications. I do tell patients, though, if you're taking these medications and you develop pain in the middle of your thigh, let me know, because then we would get an X-ray to see if you have an impending fracture. And if we see that, we have things that we can do to try to prevent it from becoming an actual fracture. The last thing you may have heard about would be osteonecrosis of the jaw. These medications cause your jaw to rot, is what I hear. So this is, again, a real side effect of these medications, but it's, again, really rare, about 1 in 10,000. The risk might be higher for those that get the same medications as part of their cancer treatment, because we do use these medications at higher doses and given more frequently in certain types of cancer treatment. But for osteoporosis dosing, we see it in about 1 out of 10,000 people treated. So again, it's so rare that the risk is low and the benefit is great. So we still use these medications. We do maybe try to avoid combining them with certain other medications that might increase your risk of the same issue of osteonecrosis of the jaw. And I listed some of the medications here, and these are cancer medications. A question, and I'll just show you a picture actually of what this looks like. And this is, obviously why people, see these pictures, and they, this is showing this ulcer at the bottom of the, or at the jaw that is not healing. And you can see here in this case, over time with mouthwashes and some gentle cleanings, it did eventually heal, but it took months and months to heal. So some cases do need surgery. So that's sort of where you might get some pictures that are more dramatic than these. So the risk is low, but one of the risk factors for this happening is dental procedures, and specifically tooth extractions. So a question that often comes up is, what do I do about my dental procedures? And the recommendation is, all dental procedures are fine, even if you're receiving these medications. The only one that will increase your risk of osteonecrosis of the jaw is if you have a dental extraction. And if you are going to have dental extraction, try to do them before starting osteoporosis treatment. But if it happens later on, just go ahead with the dental extraction. The risk is still very low. And as long as your dentist is aware, they might end up recommending some additional monitoring for healing. But beyond that, most of the time, it'll heal fine, even in the presence of these osteoporosis medications. So that's what I had to say. And, this was a rapid kind of overview of some of the endocrine issues that you might experience as a cancer patient. Obviously, there are more, and we are, as a community, happy to help you, and come see us if you do develop any endocrine complications of your treatment. Best of luck.